outputs. We move on to Dr. Subhrangshu Sengupta, all yours.
Thank you, Dr. Chandrima Paul, ma'am, and AIOC for having me here. So I'll be speaking on neurological OCT findings that mimic glaucoma. So basically, I'll be just looking at 2 or 3 cases. So first is a 49-year-old non-hypertensive, non-diabetic male who's on topical carbonic anhydrase inhibitors for the last 2 years. Open angles on gonioscopy, applanations are 18 and 20 with 520, 530 microns central corneal thickness. So now when we look at the nerves, we can easily, the first thing that strikes us is the pallor that is there in this particular optic nerve head. So now we look at the OCT. OCT RNFL shows the total thinning in the left side, and in the right side also there is advanced damage. So now when we look at the perimetry, in the right eye, we see that there is a temporal hemifield defect, and in the left eye, the defect is much more diffuse. So now we know that we are definitely, when there is respecting of the horizontal, the vertical midline, then we know that we are looking at something beyond glaucoma. Also, the last clue, the vision in the left eye is 6/60, whereas in the right eye it's 6/9. So basically, we were looking at a tumor compressing the prechiasmatic segment of the left optic nerve, and hence these chamages. Now, the second case. So here we have a 22-year-old engineering intern who was put on topical prostaglandin analogs for the last 2 years with unremarkable systemic history, normal gonioscopy, family history, father had POAG, AT was 16 and 15, and CCT was around 520 microns. So now, this is what the RNFL thickness looked like. So we have lots of areas of thinning here and here. So if we look closely at the situation, well, basically this is what the optic discs look like. They don't look glaucomatous, that's for sure. Now the final clue, the most important clue rather, the refraction. Now this patient is actually a high myope, 8.25 and 8 diopter spherical. Of course, the perimetry is normal. So basically, why all these reds and yellows in the RNFL thickness? So as has been discussed briefly, we all know that patients with myopia have a decreased image size due to ocular magnification effects, leading to a smaller measured ONH and hence an underestimation of the RNFL thickness. These patients often have blood vessels and RNFL arcuate bundles deviated more temporally. Like here you can see the bundles are deviated temporally. They should have been here. In normal people, they should have, this is where the RNFL bundle should have been, but they have been deviated temporally. As a result of which, there is an increase in the temporal RNFL thickness, and subsequently and consequently, there is a decrease in the superior and inferior thicknesses. And the RNFL peaks and arteries are shifted temporarily, resulting in, so basically these red arrows correspond to the peaks of the patient in question, and this black arrow is actually indicating where normally it should have been. So because these are shifted temporally, therefore we have this superior and inferior thinning, and that is why we get all these red areas. Now the third case. So now we have a 24-year-old lady with 16 and 17 IOP. CCT is on the higher side, 567 and 572. And visual acuity is 6/9, little myopic, yes. When we look at the RNFL, here we see that there is basically thickening here. That is why, because it is beyond the normative database, that is why it's coming as white. And this is what the automated perimetry looks like. There is quite extensive damage here. So what are we looking at? Definitely not glaucoma. So just a couple of considerations. So neuro-ophthalmic OCT considerations in the acute phase of insult to the optic nerve, For example, in ischemic optic neuropathies, there's swelling of the retinal ganglion cells, axons, which produce an increase in RNFL thickness, and therefore any axonal loss gets marked. In fact, we get thickening there. To circumvent this, the density of the retinal ganglion cell bodies which are located in the inner retina can be considered, as long as there is no coexisting macular pathology. So therefore, the concept of the ganglion cell complex comes up. So basically, the GCIP is ganglion cell bodies plus the inner plexiform layer. So ganglion cell layer basically is this part, and the ganglion cell complex is the GCIP plus the RNFL. All three put together is the ganglion cell complex. And the macular GCIP can detect ganglion cell loss in the presence of ONH edema and in patients whose optic nerves are difficult to evaluate clinically and where RNFL thickness measurements become unreliable. So in that, but in the same case that we were discussing, when we look at the macular GCC values, everything is in the red. So basically, what are we looking at? This was actually a patient of retinitis pigmentosa. So basically has been advised for all the relevant tests, but never followed up. Anyways, so just to summarize, OCT in ischemic optic neuropathy, there would be a superior and inferior asymmetry in OCT measurements. BRO, the retinal issues will be taken up by the next speaker, will similarly produce a defect that respects the horizontal midline, but unlike in AION, the inner nuclear layer would be grossly thinned in a BRO. So now the common neuroophthalmic conditions mimicking glaucoma with respect to various age groups. In the young, we definitely need to look at hereditary, post-traumatic, inflammatory, and infectious diseases. In the middle age, obviously the compressive and vascular lesions, and in elderly, the GCA. Common symptoms that are associated in neuroophthalmic cases that also we need to keep in our mind, like a sudden or rapidly progressing diminution of vision, which is typically unilateral. There is red desaturation, other symptoms like diplopia, orbital ache, and vision loss associated with headache. The signs, we look for proptosis, ptosis, loss in the central visual acuity without a loss in peripheral vision, central scotoma, pallor, RAPD, conjunctival chemosis. All these would indicate that there's something beyond glaucoma. To conclude, younger than the average glaucoma patient might not be a glaucoma patient at all. Look carefully for a neuroophthalmic disease. Pallor in excess of cupping indicates something other than glaucoma. We all know nothing notches a nerve like glaucoma. So if we get a notch, we know what we should be looking at and look for the typical neurological field defects. Thank you.